So imagine paying like thousands of dollars to have the tissue inside your own body vaporized at 200 degrees Celsius.
Right, which sounds terrifying just starting out.
Totally. And then you feel this immediate, almost miraculous tightening effect within a day or two.
Only to find out a few weeks later that the whole physical sensation was basically a temporary medical illusion.
Exactly. Welcome to you, the learner, to today's deep dive. We are unpacking a massive stack of material today. We've got complex clinical trials, overviews from NICE, guidelines from the British Society of Sexual Medicine, plus some aggressive clinic marketing materials and very stark FDA warnings.
Yeah, there is a lot to get through today.
There is. And it's all centered on energy-based vaginal rejuvenation technologies. So specifically lasers and radiofrequency devices.
Right, which are primarily marketed for conditions like stress urinary incontinence or SUI and genitourinary syndrome of menopause, GSM.
Right. And the central question guiding our mission today, the thing we really want to figure out is this: are short-term improvements reliable?
Which is such a critical question. I mean, we live in a world that is completely obsessed with rapid medical fixes.
Oh, 100%.
Ah.
But when you're fundamentally altering human tissue, does an immediate positive result actually guarantee long-term success?
Yeah, and to answer that, we really have to look at the physical mechanics of what these machines are actually doing to the tissue.
Because it's not just a simple zap, right?
Not at all. I mean, these technologies sit at this highly controversial intersection of cosmetic marketing and complex medical science. The brochures pitch it as a quick, frictionless procedure.
Like zero downtime, right?
Exactly. But on a cellular level, they're essentially hacking the body's own wound-healing cascade. And we're looking at two entirely different mechanisms here, lasers and radiofrequency.
Okay, let's start with the lasers, like the CO2 and erbium.YG devices, because the temperatures involved here are just wild.
We really are.
The clinical data shows these devices are ablating, like literally vaporizing tissue at temperatures between 120 and 200 degrees Celsius.
Right, so what they're doing is creating controlled columns of heat injury. The laser targets the cellular water in the tissue, bringing it to a boil instantly.
Wow, just instantly boiling the water inside the cells.
Yeah, it vaporizes that microscopic column of tissue and leaves a tiny crater. And the whole strategy relies on the intact tissue surrounding that microinjury acting as a reservoir.
Okay, I think, yeah.
So that undamaged tissue basically floods the zone with cytokines and growth factors to heal the burn.
So it's basically like aerating a lawn, right?
Yeah.
Or like doing a controlled burn in a forest. You purposefully punch holes in the soil, damaging the matrix so it's forced to grow back thicker and stronger.
That's a great analogy, actually. The clinical endpoints they're chasing with this intentional trauma are neocollagenesis and neoangiogenesis.
Which means new collagen and new blood vessels.
Exactly. The extreme heat forces the fibroblasts to go into absolute overdrive, synthesizing new collagen and elastin fibers.
While simultaneously stimulating those new blood vessel networks. But then you have radiofrequency, or RF technology, which operates on a totally different principle.
Right. RF doesn't vaporize the surface at all.
Yeah, it uses electrical resistance to deliver deep, penetrating heat. So it keeps the target tissue much cooler, right around 40 to 45 degrees Celsius.
Right. It's essentially using the body's own resistance to the current to generate heat deep in the submucosa.
And that causes existing collagen fibers to contract and tighten without totally destroying the surface cells like the laser does.
Exactly. But this brings us to a massive discrepancy between the biological reality of these mechanisms and what patients are actually being promised.
The marketing versus the science.
Yeah. If you look at the clinic marketing materials, you'll see all these claims of patients experiencing a distinct tightening effect within the first 48 hours.
But the medical literature, looking at these exact same devices, points out a pretty crucial physiological fact.
Which is that you literally cannot build a new collagen matrix in 2 days. It's biologically impossible.
Right. So any sensation of tightening felt in that 48-hour window is purely tissue edema.
Yes, it is just inflammatory swelling in direct response to thermal injury.
Wait, hold on. You're telling me that highly trained clinicians are looking at a swollen, inflamed vaginal wall 48 hours after burning it and allowing patients to interpret that as a successful tightening treatment?
That is exactly what is happening in a lot of these clinics.
How does that even pass a basic smell test?
Yeah.
If the immediate result is literally just inflammation disguising itself as a cure, isn't that the ultimate unreliable short-term improvement?
It absolutely is. It completely sidesteps the fundamental biological timelines required for actual tissue remodeling.
Right, because actual collagen synthesis, the
Mhm.
structural change that would theoretically treat these conditions, takes what, like 4 to 12 weeks to mature?
At least, celebrating success at day 2 is literally just celebrating the body's acute inflammatory response to trauma. It's not a cure.
Okay, wow. So we know the immediate 48-hour feeling is just edema, just
Yeah.
swelling. But what happens when the body actually gets past the swelling and starts to heal? Like, does the tissue fundamentally change?
Well, to understand the short-term biological data, we have to look at this fascinating in vivo porcine study.
Oh, right, the pig study. Because female pigs have tissue that's remarkably similar to humans.
Yes, they do. And the protocol in that study is just a masterclass in targeted tissue engineering.
They're focusing on SUI, right?
Yeah, they were aiming specifically for the urethral sphincter muscle using a 980 nanometer non-ablative transurethral laser.
The delivery mechanism for that laser is what really stood out to me.
Oh, brilliant.
They delivered 20 watts of power for 15 seconds. But to protect the surface tissue from taking the brunt of all that energy, they used this balloon-assisted diffusing applicator,
Right.
and they filled it with cooling water, circulating at exactly 6 degrees Celsius.
Yeah, that cooling balloon is such an ingenious piece of engineering. It physically presses against the urethral wall, basically freezing the superficial mucosa.
So the surface stays safe.
Exactly. It allows that 980 nanometer wavelength to bypass the vulnerable surface and deposit its thermal energy deep into the submucosa and muscle layers.
Without causing irreversible surface burns.
Mm-hmm.
And the short-term biological response they saw at day 28 was just
It
explosive.
was massive.
The urethra thickness in the treated group was 46% greater than the control group, a 36% increase in wall thickness in less than a month.
And they also tracked the proteins. VEGF, which stimulates blood vessel growth, spiked by over 141%.
Alongside this huge upregulation in collagen type 3 deposition, I mean, visually under a microscope, it looks like a 28-day biological miracle.
It does. But we have to look at the researchers' own limiting conclusions to understand the functional reality here.
Right, the whole so what factor.
Exactly. A 46% thicker urethra at 28 days is a profound anatomical change. But increased wall thickness doesn't automatically translate to an actual functional cure for urinary incontinence.
Right, because biological thickness and functional pressure just aren't the same thing. Just because the wall is thicker doesn't mean the sphincter can actually hold tension better under stress.
Precisely. The clinical gold standard for measuring incontinence is leak point pressure, or LPP.
And a thicker wall from a sudden blast of collagen doesn't guarantee that the LPP actually improves.
No, it doesn't. Furthermore, the researchers openly noted they couldn't even confirm if this sudden thickening was a durable architectural change.
Oh, so it might just go away.
Yeah, they couldn't rule out if a significant portion of that 46% increase was still just a lingering, transient inflammatory response that would eventually subside.
So think about the parallels here for your own life for a second. How often do you see a single biomarker shift on a blood test or some number jump up on your fitness tracker and you just assume the underlying systemic issue is totally resolved?
We do it all the time.
Right. We see a 36% increase in tissue thickness and assume the incontinence is completely cured. But driving up a specific metric in the short term doesn't mean the biological system is actually functioning better long term.
Which is exactly why we have to pivot from animal histology to human clinical trials. A thick tissue sample in a lab doesn't tell us what happens to a human patient 6, 12, or 24 months down the road.
Okay, so let's pull up the human data. Let's look at the Fujian Maternal and Child Health Hospital study.
Yes, that one is very revealing.
They ran a direct comparison between CO2 laser therapy and radiofrequency therapy for women dealing with SUI.
Right, and they stratify the results by the severity of the incontinence. At the 6-month mark, the CO2 laser looked incredibly reliable.
Like almost too good to be true.
Yeah, it boasted an 86.5% overall effective rate. And for patients with mild SUI, it achieved a 92.6% success rate.
Based on objective 1-hour urine pad tests.
Right.
I mean, if a pharmaceutical company stops the trial at 6 months, they have a blockbuster cure on their hands.
Oh, absolutely. Over 90% efficacy is life-changing for these patients.
But the timeline didn't stop at 6 months.
No, it did not. By the 12-month mark, the clinical landscape completely inverted.
It just crashed.
The CO2 laser's overall effectiveness plummeted from 86.5% down to 51.9%. The biological effect essentially just evaporated.
Wow.
Meanwhile, the radiofrequency treatment, which actually had a slightly lower initial success rate at 6 months, showed far better sustained efficacy at 12 months.
Especially for moderate to severe cases. It maps perfectly to a sprinter versus a marathon runner analogy.
Oh, I like that. How so?
Well, the CO2 laser is the sprinter, right? It ablates the surface, creates intense superficial trauma, and forces this massive, rapid tissue contraction.
Right, you get a plump mucosa very quickly.
Yeah, which temporarily seals the urethra better.
Yep.
But it's entirely superficial. The RF device, because it relies on electrical resistance, bypasses the surface and penetrates much deeper into the fascia.
Into the pelvic ligaments, yeah.
Exactly. It's playing the long game. So the laser wins the 6-month sprint, but the RF sustains the 12-month marathon.
That's incredibly accurate. The laser's thermal energy is highly powerful, but its penetration depth is strictly limited to the vaginal mucosa and lamina propria.
It just can't reach deep enough.
No, it simply cannot reach the deeper pelvic fascial ligaments that actually provide structural support to the urethra. So once that initial burst of collagen naturally metabolizes over the year, the structural weakness is still there.
And the incontinence just returns. And this steep drop-off isn't even isolated to incontinence. We see the exact same 12-month fade when these lasers are applied to GSM and vulvovaginal atrophy.
Yes, the VVA data is very similar.
If you look at the data synthesized in the NICE overview, specifically the Gambachiani study tracking 254 patients.
Right, they used a visual analog scale, or VAS, to objectively measure symptoms like dryness and painful sex.
And at the 6-month checkpoint, the improvements were beautiful. The scores for pain and dryness dropped significantly.
Indicating a very strong biological response to the thermal injury.
But then they tracked that same cohort of women out to 24 months, and the satisfaction rates just fell off a cliff.
By 12 months, nearly 30% of the patients had already required a repeat procedure just to maintain baseline comfort.
And by 24 months, out of the original 254 patients, only 5 patients, just 2.4%, were still satisfied with the results.
2.4% satisfaction at 2 years really exposes a hard biological truth about neocollagenesis triggered by thermal injury.
It just doesn't last.
Right. Because of the natural aging process, ongoing mechanical wear, and the continuous hormonal deficits associated with GSM, the newly synthesized collagen degrades.
The permanence is a total illusion, and it completely validates what we found buried in the fine print of the clinic marketing sources.
Well, the maintenance trap.
Yes. You have these high-end clinics boasting about stopping bladder leaks with a single treatment. But then you dig into their FAQ sections, and they casually mention that after your initial series of expensive sessions, you will require annual maintenance every 12 to 18 months indefinitely.
Indefinitely. So if the data so clearly demonstrates that the physiological changes revert after a year and the clinical reality requires endless maintenance sessions, we really have to look at why the term vaginal rejuvenation dominates the market so heavily.
And why regulatory bodies have had to step in so aggressively.
Exactly. Let's look at the ACOG stance. The American College of Obstetricians and Gynecologists doesn't even recognize vaginal rejuvenation as a legitimate medical term.
Really? Not at all.
No, they categorize it firmly as a marketing buzzword. They group it under designer vaginoplasty, basically cosmetic procedures that lack a clearly defined evidence-based medical purpose.
Wow. And the FDA escalated the issue way beyond just terminology.
Well, they certainly did.
In 2018, they issued a stark, formal warning against the use of energy-based devices for cosmetic vaginal rejuvenation.
Citing a severe lack of long-term scientific evidence supporting their safety and efficacy for these off-label uses.
And honestly, if the FDA is issuing warnings like that, how are these machines still sitting in strip mall med spas across the country?
It's a massive regulatory loophole right now.
Because when you cross-reference the FDA safety reports with the adverse event logs in the NICE overview, the dark side of chasing this rapid short-term fix becomes incredibly grim.
It's not just about the treatment wearing off.
No, we aren't just talking about symptoms returning. We're looking at reports of catastrophic adverse events, vaginal burns, severe internal scarring, third-degree thermal burns, and a chronic debilitating pain.
There is a highly documented case study in the literature that illustrates the cascading risks here perfectly.
A 61-year-old woman, right?
Yes. She presented with mild dyspareunia, so manageable mild pain during intercourse. She was prescribed 3 courses of laser therapy.
Okay, so she goes in for a minor issue.
Right. But 10 months later, Right around the time that initial superficial collagen boost naturally fades, her pain hadn't just returned to its previous baseline, it had become progressively severely worse.
She went in for a fix for mild discomfort, and 10 months later, she is in agony. What actually happened to her tissue?
Well, upon clinical examination, she presented with moderate vaginal dryness, severe vestibular inflammation, and profound pelvic floor hypertonus.
Which means her muscles were basically locked up.
Exactly. Her levator and vaginal muscles had locked into a state of chronic spasm. The body's natural reaction to repeated, intense thermal trauma is often defensive guarding.
So her pelvic floor essentially clamped down to protect itself from the injury.
Yes, and it deteriorated her condition, the point where she actually required intravaginal Valium just to suppress the newly induced spasms and pain.
That is horrifying. And that is the absolute core conflict staring at us from these sources. On one side, you have clinic websites marketing a frictionless 3-minute high-tech miracle with zero downtime.
And on the other side, you have patients requiring localized Valium just to survive the chronic muscle spasms induced by the cure.
Unbelievable.
And the clinical guidelines from the British Society of Sexual Medicine, the BSSM, they present a very sobering counter-narrative for treating these conditions.
Right, like for a condition like GSM, the BSSM strongly recommends targeted topical vaginal estrogens,
Yes,
which crucially does not involve vaporizing anything at 200 degrees Celsius.
exactly. The BSS emphasizes that the clinical response to topical estrogen is not only rapid but highly sustained as long as the treatment is maintained.
Because it's treating the actual cause, not just burning the symptom.
Right. It fundamentally restores normal vaginal pH, thickens the epithelium naturally, revascularizes the tissue, and decreases the incidence of urinary tract infections.
It addresses the root hormonal deficit safely, without introducing the severe risks of third-degree burns or generating restrictive scar tissue. Man, we have unpacked a massive amount of clinical data today. Let's build this all together and return to our mission for you, the listener. Are short-term improvements reliable?
Based on the animal models, the human trials, and the FDA safety reports, a very distinct biological reality emerges.
Yeah, I mean, energy-based treatments like CO2 lasers and RF devices undeniably trigger a rapid, highly measurable, short-term physiological response.
The thermal injury forces the surrounding tissue to thicken, rapidly synthesize new blood vessels, and acutely reduce symptoms around the 1 to 6 month mark.
So the short-term biological change is real. We can't deny that.
It is real, yeah.
However, interpreting that short-term trauma-induced response as a permanent structural cure is a fundamental mistake.
Absolutely. The clinical data proves that these effects demonstrably fade by the 12 to 24 month mark.
Dropping to near zero satisfaction in long-term tracking.
So the essential takeaway here when evaluating any heavily marketed, energy-based medical technology is that you have to separate the immediate physiological reaction from long-term functional healing.
Temporary inflammatory swelling and an initial blast of collagen are not synonymous with a permanent cure.
They just aren't.
Look, we all want the clean diagnostic X-ray. We all want the 3-minute laser zap that fixes complex biological decay forever.
It's human nature to want the quick fix.
It is. But human tissue is relentlessly complicated, and manipulating it always comes with a cost. So I want to leave you with a final thought to mull over, building on everything we've explored today.
Okay.
If a treatment protocol requires you to repeatedly inflict microscopic thermal injuries on your own tissue every 12 to 18 months just to maintain a baseline of comfort, at what point does the cure simply become a newly manufactured chronic condition?
That is exactly the kind of question we need to be asking when navigating these murky medical waters.
Thanks for diving deep with us today. Keep asking the hard questions, keep looking past the glossy marketing, and we'll see you on the next deep dive.